Buenos días, good morning. Buenos días, Salamanca. ¿Me oís? Hola, Salamanca. Soy Paco. Oviedo, ¿me oís?
Te oímos perfectamente.
Buenos días, César. Gracias por conectaros. ¿Cómo estáis?
Muy bien, muy bien. Aquí estamos esperando.
¿Qué tal París?
No lo vimos, pero hubo huelga de taxi, hubo de todo, ya lo sabes. Siempre hay un follón.
Está aquí nuestra gerenta jefa. Dile cuánto va a aumentar el gasto de la TAVI después de París. Díselo para que se vaya preparando.
Muy buena.
Salamanca.
Solo decir
Buenos días, Paco.
Que realmente
Buenos días, Paco.
Buenos días, Ana. César.
Bueno.
No, ya os damos ya la palabra. Vamos a cerrar nuestro micrófono, ¿vale?
Vale. Bueno, gracias por conectaros, César. Ana, ¿qué tal? ¿Cómo estáis?
Estamos fenomenal, con muchas ganas de empezar la reunión.
Bueno, pues vamos a empezar. Ya sabéis que esta actividad que llamamos los encuentros con expertos en medicina cardiovascular, la venimos haciendo, este es el año número 12 que lo hacemos. Por diferentes motivos que son sobre todo de carácter económico, este año solo hemos podido hacer este encuentro, que es un encuentro muy especial y que se encuadra, como todos los demás, en el programa de formación del Servicio de Cardiología y de la Facultad de Medicina de la Complutense y también dentro del programa de formación del cibercardiovascular y que se hace en conexión directa con dos centros de este entorno, que es el Hospital Clínico Universitario de Salamanca y el Hospital Universitario Central de Asturias, dentro de lo que es el ámbito del cibercardiovascular. Las primeras palabras son de agradecimiento pues a nuestros amigos de Salamanca y de Oviedo, a todos vosotros que estáis aquí y a la institución, y muy particularmente I would like to thank the presence here of Hugm. This is a very good friend and is part of the excellent relationship we have with the cardiovascular division of the Mayo Clinic. We, for years, have sent many of our fellows to there and have a very, very strong relationship with this incredible institution. And thanks to that, we were able to identify the problem of cardio-oncology and had the opportunity to exchange information and knowledge with Jörg Hermann. Jörg Hermann is from Germany. He finished the specialty of cardiology in Germany and then came to USA, to the Mayo Clinic, and have developed an incredible, terrific career in terms of both care of patients and research. In fact, he is responsible for the cardio-oncology clinic of the Mayo Clinic and have produced a lot of knowledge, a lot of data in the intense research activity, and is actually an obligatory member of all consensus documents and guidelines related to the topic. So many thanks, George, for being here with us. Welcome again to Madrid and to our hospital. Finally, I would like to thank the institution, our institution, el Hospital Gregorio Marañón y la dirección de nuestro centro apoya con bastante interés todas nuestras actividades y ha sido especialmente sensible a la necesidad de apoyar este proyecto de cardio-oncología que en los 2 o 3 últimos años se ha estructurado ya completamente y está funcionando de una manera sólida. Vivimos en un hospital donde diferentes especialistas de patología y digestivo, oncólogos clínicos, oncohematólogos, oncólogos radioterápicos desarrollan una intensísima actividad en la lucha contra diferentes tipos de cáncer, con un número de pacientes enormes a los cuales nosotros siempre hemos pretendido atender de la mejor manera, y creo que ha sido así. Pero hace 3 años aproximadamente nos dimos cuenta de que eso no era suficiente, de que la atención normal de estos pacientes, aunque fuera enormemente precisa y con una gran dedicación, era insuficiente, como digo, y que teníamos que tener un programa estructurado, creado de manera consensuada con todas las disciplinas que se involucran en el manejo de los pacientes que reciben tratamientos quimioterápicos y que pueden o tienen de hecho ya daño cardiovascular. Y este fue el motivo por el cual empezamos este proyecto que, como he dicho anteriormente, ha apoyado muy fuertemente desde el principio la dirección del centro y que sobre todo ha contado con la presencia de una gente extraordinaria de todas las disciplinas implicadas y que van a estar hoy aquí en el panel para discutir con nosotros todo lo que nos pueda enseñar el doctor Hugm y nuestra modesta propuesta para abordar este problema. Así que muchas gracias a todos, muchas gracias Sonia, y tienes la palabra.
Bueno, buenos días, bienvenidos al Hospital General Unitario de Rebolledo, a los que estáis aquí y a los que estáis en modo virtual ahí en Salamanca y en Asturias. Gracias por compartir este encuentro con nosotros. Para la dirección siempre es un reto. El servicio de cardiología es un servicio de aquellos que no te deja estarte quieto ni parado. Es el servicio que tiene un impulso, uno de los que más impulso tiene en el hospital y que siempre nos está sometiendo a los retos, independientemente del coste que podamos discutir de los productos sanitarios. Y para mí siempre es un placer pues, estar compartiendo con vosotros estos pequeños minutos, aunque voy a intentar quedarme a la charla para exactamente saber cómo al final hemos conseguido organizarnos y lo que podemos aprender de la Clínica Mayo. Quiero resaltar que, como sabéis, dentro de la estrategia del hospital nos pusimos como misión mejorar la salud y la calidad de vida de los pacientes. Cuando hablamos de un término tan general en el ámbito de la oncología, no se trata, por tanto, no solo de tratar a los pacientes bien durante el hospital, durante las fases más agudas de la enfermedad, sino acometer el reto de los largos supervivientes, que antes lo hemos estado comentando con el doctor Hugm, en el ámbito de la oncología y de todos los pacientes, sus complicaciones después de los tratamientos oncológicos, tanto de quimio como de radio, y que afectan al ámbito del área cardiovascular, ¿no? Cuando el doctor Fernández Avilés detectó que era una área de mejora clara en nuestro hospital, evidentemente era un reto y la dirección consideramos que había que asumirlo como tal y lo apoyamos. Forma parte, por tanto, de nuestra estrategia futura del hospital y a la que estamos caminando todos, ¿no? Hemos creado el Centro de Enfermedades Inflamatorias mediadas por la Inmunología con un concepto de atención interdisciplinar y multidisciplinar e integral para el paciente, en la que el objeto de la atención es lo que necesita el paciente, y estamos cambiando la manera de organizarnos en el hospital. Y esta manera de cambiar la manera de organizarnos en el ámbito de atención de las enfermedades inflamatorias, en el ámbito de atención de la psiquiatría, en el ámbito de la atención de la cardiología o de la patología oncológica, pues esta iniciativa forma parte de ellas. Yo creo que crear un programa interdisciplinar como el que se va a exponer aquí es básico para ese camino que tenemos hacia la excelencia y a la excelencia en el caso de los pacientes atendidos, pacientes oncológicos. Quiero dar las gracias a todos los que participáis en la atención a los pacientes oncológicos. Evidentemente, formáis un equipo importante. Tanto la sensibilidad que tenéis los oncólogos, los radioterapeutas, los cardiólogos, los farmacéuticos, el personal de enfermería y muchas otras especialidades que hacen que los pacientes nos elijan para ser atendidos cuando tienen un problema oncológico. ¿Por qué? ¿Porque tenemos un magnífico servicio de oncología? Sí, pero porque también tenemos un magnífico servicio de cardio, de oncología radioterapia, de farmacia, etcétera, ¿no? Digo unos cuantos, pero podría ir un personal de enfermería que los atiende de una manera exquisita. Permite recordarme que ayer, ¿no? Antes de ayer le entregaron el premio de la lámpara de Florence Nightingale a una enfermera de oncología y que fue elegida por los pacientes oncológicos. Eso quiere decir no solo que estamos organizándonos de una manera excelente para unos cuidados técnicos o una calidad técnica excelente, sino que también tenemos una calidad humana muy buena. Por tanto, os animo a seguir trabajando así. os animo a que nos sometáis también a la dirección, a los retos que suponen cambiar este modelo diferente de atención, no por servicios, sino realmente en torno a lo que necesita el paciente. Le agradezco al doctor Hugm que venga aquí, evidentemente porque tenemos una muy buena relación con la Clínica Mayo. Nuestros residentes terminan la formación en su clínica y el hecho de poder tener una alianza estratégica con ellos para aprender de las mejores prácticas, pues supone avanzar y es un reto para nuestra organización. Espero que aprendamos todos mucho de esta jornada y que luego la dirección, aquí está el director de enfermería conmigo, nos llevemos otro reto más y cómo mejorar más la atención en nuestro hospital con vuestro apoyo y con toda vuestra participación. Muchas gracias y yo creo que lo importante ya son las charlas y que todos aprendamos de ellas.
So let's start with the meeting. Eduardo.
So good morning to everybody. Good morning to Oviedo and Salamanca. Hello. It's a pleasure to be...
Salamanca is also here.
Salamanca is also... Pedro, welcome. Good morning to everybody. It's a pleasure for me to be here, and the first words as well is to say thank you to the organization, to Paco, to Ana, and to the also the headmasters of the hospital, because they are supporting the project, and also to all the people that make the project happen. My cardio mates, Mariana, Sara, Ana, and also Ana González Mansilla, that cannot be here today, but is with us anyway. And thank you to all the mates also from oncology, hematology, and radiotherapy, that we have a different and new and I think very good relation in the last months. So, starting with the talk, I'm going to show you what we have been doing in the last 1 year and a half, and I'm starting introducing the topic because it's a fact that cancer prevalence is increasing, because both survival is increasing and also the aging of the population is increasing, and in developed countries like Spain it would be a next future challenge, because probably it's estimated, for example in the States, that 15 million people would need some cancer treatment in 2040. Every day, new molecules, new clinical trials in chemotherapy are arising, and is that faith a new future with a lot of hazards of cardiotoxicity, and also the cardiomyopathy and the cardiovascular risk factors in this aging population is going to make a change in the care of these patients. Also, cardiovascular morbidity, because of the toxicity and also the cardiovascular risk factors and cardiopathy of this age population, impact in cancer survivors. And as you can see here in the graph, it starts even at the very young people and young population with cancer. And the spectrum of the toxicity and the cardiovascular disease in cancer patients is very wide. The mechanisms of why cancer treatments affect the cardiovascular systems are not well understood and are multiple. They can cause myocardial damage, pericardium disease, valvulopathies, vascular disease, pulmonary hypertension, all of the spectrum of cardiovascular disease, and it can make to appear all the 4 big syndromes in cardiology that we are used to treat and that we are usually seeing in our daily clinical practice. So from different organizations, the attendants of these patients try to be, or they are advised to organize these cardio-oncology equipments, treatment services, teams, and with mainly two goals. One, unification of the cancer care process and allow patients to have a uniform treatment without starting and stops of the treatment because of cardiovascular disease, and also prevention, monitoring, detection, and treatment of toxicity. To do it, the proposals starts in a core nucleum, the cardio-oncology teams that have a core member, of course, all the professionals that treat cancer and the cardiologist. But we cannot work alone in that field, and we need a lot of help of many other specialties that usually treat also patients with cancer. Pathologists, family doctors, pharmacists, psychologists, palliative care, and to hold them together, coordinated, and to give some clinical pathways for those patients is what they propose as a cardio-oncology clinic. When you have a hallmark like this hospital, that is a tertiary hospital with all of the resources that you can imagine, and with the potential of research and educational, then you have a cardio-oncology service. So, in our case, this is a very simple schema or model of the vision of the cardio-oncology in our hospital. There are many specialties treating cancer patients, and of course, cardiology cannot treat all of the patients or see all of the patients that all the specialties that treat cancer see. So we have developed some unified criteria to make a filter and to select the high-risk patients that can benefit more from our help and treatment. Our mission in cardio-oncology is to discuss these patients and to have clear clinical pathways to give a feedback to those professionals of what to do about all the related cardiovascular disease. So that we need to talk frequently with pharmacy, immunology, pathology, rheumatology, surgeons, anesthesia, all the professionals that intervene in the process of those patients. And of course, the help of our mates in cardiology department is basic. We need the hemodynamist, the rhythmologist, we need the imaging very much, and some patients need even advanced therapies or cardiovascular surgery. As I saw in the slide before, we have a very good hallmark in our hospital that allows to have the resources and the potential of research and education of a very big and a good tertiary hospital. So our first thought was to create a director corps where oncology, hematology, radiation oncology, and cardiology are represented, and to have the coordinators that can give, with this inverted pyramid scheme, support to different areas of committees that allow and let the professionals of the hospital treat a big amount of cancer patients in the best way, looking at the cardiology point of view. So these unified criteria that we have consent with the participation, active participation of all those four disciplines is like that. The first step, if the patient that is receiving any anti-cancer treatment has cardiomyopathy, we think he or she can be derivated to the cardio-oncology clinic, and also if there are some anomalies in the ECG or there are symptoms about cardiology disease like syncope, chest pain, short of breath, whatever. There is also a special pathway for the patients that have electrical devices, pacemakers or ICD, and we have created a protocol of monitorization and care during the radiation therapy. Also for patients that we think that have a high cardiovascular risk and they can benefit from first prevention or secondary prevention of cardiovascular risk factors, we are pleased to receive them in the consult, and also the patient that has high cardiotoxicity risk with the criteria on the right, that we think that they need a special follow-up and some advices to be treated with cardiotoxic therapies. Also, at the evidence of cardiotoxicity, we recommend also to derivate patients to cardio-oncology clinic with the criteria of depressed ejection fraction, new appearance of symptoms or arrhythmia, or the rise of biomarkers. And another problem, or not problem, but another challenge, is the long survivors, to protocolize the follow-up and the surveillance of the cardiovascular disease and morbidity in these high-risk patients. So the way to do it could be from the ambulatory or also during the hospital admission. This is working since September that we started with a consulting and you can create an interconsultation from the ambulatory clinic to request a consultation in the monographic cardio-oncology consult. Also, if the answer is urgent, you can contact us in the ward cell phone or during the ward time or during the mornings in the interconsultation phone. And also the natural way of interconsultation at the hospital admission, we will evaluate and see the patient as well. To uniform treatment and to try to apply the evidence that we already know, we are developing local protocols. Some of them are nearly ready to be approved, and some of others are still work in progress. And also the help of nurses that are starting to aware the patients about the cardiovascular risk and the importance of the habits, healthy habits for the treatment, not only the cardiovascular morbidity but itself the cancer. It's started, and we have this material from the Mimocardio, that is a group of cardiologists in the Society of Cardiology of Spain that have developed this information for patients. About educational and research, there is or start to be a scheduled rotation in cardio-oncology. Actually, one oncologist resident has been with us during 1 month, and it was a very nice experience. And there are planned another 2 stays in the cardio-oncology for 2 other oncology residents. Also, there have been some presentations of the program at all the oncology, hematology, and radiation oncology during autumn, and there have been residents talks with reviews, literature reviews and case reports in this topic. Also, in the research part, in the clinical part, Anna told us the rationale of the Cartier study that comes from Salamanca, and that we are very happy to participate, and we expect, very excited to start with the project. And also, as Paco said before, we have some basic research that could start in collaboration with the Med&Home in a murine breast cancer model. So, as a brief message to take home, I think they work together in the hospital to avoid the cardiovascular disease and undertreat cancer in those patients, or overtreat cancer and provoke cardiovascular disease without taking care of that is not good, and we have to find the balance to assess the risk of cardiotoxicity in those patients, have an aggressive control of cardiovascular risk factors, also to create a systematic follow-up that can allow to detect, prevent and monitor the cardiotoxicity, develop also tools of cardioprotection and apply the evidence, still little, but about the protective drugs and therapies, and also to share these difficult decisions that sometimes affect this kind of patients. Also, the treatment as soon as possible of the cardiotoxicity is another of our goals. So, thank you very much for your attention, and if you have any questions. I give now the word to George Herman, and we can make the discussion after the talk with the panel in the table.
Thank you so much. A deep thanks to Paco for inviting me, everyone who was involved in the organization to make this possible. It's a true honor to be here, and I agree for two hospitals to work together, more so in the future. I was saying yesterday, it was so nice when I arrived at the airport, I saw Mayo. And I thought they really loved the Mayo Clinic until I got it. It's the May in the calendar. But no, you really truly make me feel very welcomed here, and so I'm deeply grateful for all the wonderful colleagues and the interactions we had yesterday. And I also have to say, when Paco gave me the topic and the title, we do not want to have, and for the topic of this talk, I thought it would be good to reflect on the takeoff of cardio-oncology, the past, a little bit of it, to summarize the current trends and developments in cardio-oncology, the present, and then to outline the needs and goals of this discipline, the future. Eduardo elegantly alluded to it already. So when we looked at the map of the US in 2011, what was out there for cardio-oncology and for cardio-oncology clinics, it were just a few. And a few years later, you can see the growth. In 2016, this is how it looked. So you see the tremendous increase that had occurred. And this is 2019. It's not a political statement, at least I hope it won't go to this color completely. But there are too many to count right now in the US as far as programs are concerned, and I think you see the same here in Europe. In South America, there's also a lot of activity. So it's not just confined to the US, it's really a global. And the plane has really taken off. And I think the question is, where are you? Are you a spectator, just looking down from the bottom? Are you a passenger? Or are you a pilot? So I think that's a few of the questions to entertain. And if you're a spectator, you might entertain the question, do I get on board? There's a lot of skepticism in various places, which is good. And passengers who are on board may be wondering, am I sitting in the right place? Do I need to change something? Do I need to change seats? And the pilots obviously thinking of how they can help leading the way and defining the direction. And so let's take a look first at the spectator. And they have seen, and Eduardo has shown, position papers that have been published, guidelines. One of the most recent is to the right. It's from the American Society of Clinical Oncology. It's an actual practice guideline. And so you can't really live this day and age without recognizing that this field is emerging. And I'm truly impressed that Spain is leading the way, in a way. So there are one consensus paper in cardiology, there's the Spanish Society of Cardiology to the left, but then also in oncology. There's actually a cardiotoxicity guideline, as you can see. And I think this is a wonderful example of how it should be, the publications in the cardiology journals and in the oncology journals, and joint efforts building bridges in this area. And Anna has been instrumental to this as well. And so I think this is excellent, and Eduardo already outlined the goals of the cardio-oncology clinics, which were recapitulated in these documents, and so I won't do this. And this is what the head paper, the first page of what you showed. Now, last October, when I had the honor to be with you for the first time, this is what we looked at in greater detail, and it was at the time to brainstorm how can we facilitate, or what have we learned, and what can we share and pass on how to develop a cardio-oncology clinic. And we said at the time that this is an evolving field. It's not in a standstill, it's really dynamic, and that there are 3 milestones and each have 3 steps, just as a rough outline. But it's very important that each place is individual. It needs to individualize. What works at our place might not work here. And so I was really impressed, Eduardo, to see, I mean, you've done more in 1 year, or not even a year, what we didn't accomplish in a decade. So it's really, really great to see. And it's really nice to see how this evolves. And what we said the milestones were are first the vision and the goals. You really have to know where you're going, what you try to accomplish, and where you want to head, and then have the institutional support, which is fantastic and it's absolutely key, it's crucial, and then to implement and operate, and at the end keep refining it. And the overall structure, again, needs to be within the scope of practice. What do you see, which entities of malignancies, hence which therapies, hence which toxicities. So I think there is a clear definition, and it starts and falls really with oncology and hematology, radiation therapy. It's really that patient population. And then the structural confines really dictate how you organize this clinic. And so today is the birthday of Bob Dylan. He's a Minnesota native. And so he wrote this, come together round people wherever you roam, and admit that the waters around you have grown, and accept that soon you'll be drenched to the bone. If your time to you is worth saving, then you better start swimming, or you'll sink like a stone, for the times they're changing. So I could never understand why this guy got the Nobel laureate in literature until I read this poem. And so the times are changing. And the face of cancer care has changed radically over the past decades, from acute chemotherapy infusion to chronic therapy, injection or pill, from inpatient to outpatient, from limited number of chemotherapies to now an expanding arsenal of agents, from general and common side effects to unique toxicities, and from short-term survival to long-term survival. And the last point, I think, is really key to all of this, because this is a major game changer. What was not maybe relevant in the bigger scope a few years ago now very much is, as patients living with cancer, not necessarily dying from cancer. And this is a slide that you've likely seen before as far as this oncological revolution. and the ever so declining cancer-related mortality from the 1990s, and on the flip side, the ever increasing numbers of survivors. This was 2008, and this is the projection which is now more timely as how we're doing in the US with cancer survivors. And you can see a tremendous growth that's projected here to nearly 20 million very soon. And what's very pertinent is that these are not short-term survivors, a year or two, but we're talking about long-term survivors, 5 years from diagnosis or more. When we look at 2002 and we look at 2022, you see that the greatest increase will be in these long-term cancer survivors. So they live with whatever toxicities they endured during the therapies and will for the rest of their lives. And what's also very pertinent, and Eduardo alluded to this, is that the greatest growth in the cancer prevalence and then also cancer survivors will be seen in this bracket from green, purple to blue, which is what we call the Medicare population in the US, 65 years and older. It's really seen in the elderly. This goes with a trend, the aging of the US population. We call it the silver tsunami. That's the wave we're surfing on right now. And no matter if you look in 2000 or 2004, as these Canadians did, aging is a risk factor for cancer and cardiovascular disease. They go hand in hand. And so it's very likely to find a patient with malignancy that also has cardiovascular disease. And we also have the heat map of the fatal coincidence of heart disease-related death in the US and cancer-related death, and you do see how they match up. Patients seem to die for one or the other, or with both diseases together. And one of the forgotten truths, I think, is that when we put it into perspective, the prognosis of heart failure and MI, first hospitalization of MI, these are data from the American Heart Association to the right, and to the left, you see those quoted for malignancies, Hodgkin's lymphoma, breast cancer, colorectal cancer. And as you can clearly see, up to the regional metastasis stage, the prognosis for the malignancy is better than it is for heart failure and MI. So this is something that patients, in particular, are often not aware of. What this also means for us, and this is a conceptual thought, is that if you have a patient with Hodgkin's lymphoma, treat them with an anthracycline-based regimen, and they developed anthracycline-related heart failure, you essentially reduce their 5-year prognosis dramatically, from 90% to 50%. And so it's not trivial. It's another example. We talked a little bit in a case yesterday about diffuse large B-cell lymphoma. These are data from the elderly population, and anthracycline containing regimen ACR and Rituxan containing regimens are labeled here. And you can see clearly the green line is the anthracycline based therapy, and that has the best outcome. And so if a patient develops anthracycline cardiotoxicity, what does that mean in this scope? Well, it means that the patients will shift to non-anthracycline based therapies or to no chemotherapy. So this really limits the ability of our colleagues to do what they feel would be otherwise best for the patient in terms of treatment plans. And it also, drastically shifts to inferior outcomes. Now, looking at those who have received anthracycline-based therapy, and let's say they develop heart failure, this would be the projected line. If from what we have in the literature for the survival plot for patients with symptomatic heart failure, we're talking stage C, not talking stage B. So what you can see is that, at the end, it meets the non-systemic therapy line on the bottom. And in other words, maybe too drastic to say, but it annihilates the treatment benefit. So at the end, the patients are the same way as they would be as they never received chemotherapy treatment. So the face of cancer therapy is changing, and we're going to see more patients, we're going to see more survivors, we're going to see older patients, more comorbidities, more cardiovascular diseases. I think the question is, who is going to see and take care of these patients? For those who are watching, who are just spectators, I think that's a key question for them. Some have this already taken on. Those are the passengers. Those are the ones who are on board with this, flying with us, cardio-oncology airlines. And what they might be interested in is the change in therapies that have occurred over time from classical chemical chemotherapeutics, then the classical targeted therapies, and now we're in the new area of immunotherapy. And we had immune checkpoint inhibitor discussions yesterday. I think this is the latest, this is the current era. And you can see in the plots that in yellow, cardiotoxicity has always been of greatest interest. It changed a little bit during the targeted therapy era. And then, as you can see, all of these are really taking off in the most recent time. Also increased attention to arrhythmias, vascular disease aspects. So, but still, cardiotoxicity is remaining the #1 interest. And when we look at the drugs that we now have to take into closer consideration in this clinic in particular, I mean, it's really broad. I've just listed a few among those classical ones. And looking forward, what's in the pipeline and what's coming. So this is a group a year ago compiled this very nice report looking at the new cancer therapeutics that were approved in the US in 2017. The bottom line is that all of these are targeted therapies, that nearly half of these are immunotherapies, that 11 have orphaned indications, so we're going into more and more specialized and unique applications, and 10 out of these 14 were approved based on phase 1 or 2 trials. So not a lot of testing done, but really a quick rollout into the clinic. And most of these, or I mean, when you look at the number of new drugs listed, most of the development in leukemia, lymphoma, and lung cancer. So those were the ones that topped the list here as was newly introduced. And when we look at lung cancer, it's really seeing this immune checkpoint inhibitor revolution. They're really, at least in 2017, were accounting for nearly half of the use of these new drugs, and then melanoma, renal cancer, head and neck cancer, those are the other main contenders. But it's now spreading out so much. In fact, there's legitimate fear that we won't have enough patients to enroll all the trials we've planned with immune checkpoint inhibitors. And the immunotherapy or immuno-oncology revolution, it just doesn't stop there. It's not just immune checkpoint inhibitor as we know it right now. When we look here, we can see to the right the hematological malignancies, CAR T cell therapy is very much progressing. When we look at the solid tumors to the left, we see there are also TLR agonists, oncolytic viruses that are being unleashed. So a lot of modulation in this, and whereas we had 4 mechanisms to look at in the past when it came to immunotherapies, we're now likely looking at 60 mechanisms or more in all sorts of shapes and variations, combination therapies. So it's just an ever-expanding spectrum that we're going to deal with, and the question, who is going to deal with this? The new drug pipeline also expanded quite a bit from 2007 to 2017. We've seen a 60% growth as far as what's coming. And this is more drugs than ever before. Most of them are targeted therapies, especially immunotargeted. And I've alluded to this earlier with the phase 1-2 trials accounting for most of the data generating approval already. There is a shortened road to what's known preclinically, to what's known early clinically. So what it means to us is we will encounter likely still a number of surprises as more and more patients are going to receive these new drugs. And I think this field will not be dormant. I think we will see a lot more coming and things we haven't seen even before. And it's not just about the drugs, it's also about other changing elements. I think this is also very important. We've talked about immuno-oncology. There's a lot of efforts about individualized precision medicine that's being advanced, high-tech developments, 3D printed implants, imaging advances, And then the artificial intelligence, AI, that's something that we are also very interested in cardiology at Mayo, but it's also a lot happening in oncology. And it's really phenomenal how, I mean, algorithms, I don't know if you're aware of it, as far as looking at a chest X-ray, looking at a chest CT, how these devices and machines, artificial readers can be trained to be better than a radiologist as far as picking up malignancy, distinguishing based on the features, whether this is malignant or benign, and even pathology. There was a wonderful Nature Medicine paper last year looking at histology specimens and scanning and being able to differentiate much better. I mean, look at the AUC curve as a pathologist would, even telling which mutations are present in the tissue. And so it's really phenomenal. So that's something I think will be more and more need to be prepared for as what's coming in this particular area. And then there are the registries. I know in Europe you have some regulations that might give some headaches or not, but also have wonderful opportunities, all these national registries you have. But it's going to be an ever-expanding scope and interest, and we need to build this in cardio-oncology. I think it's key to emphasize the collaboration need, because some of these toxicities are still very rare, and unless, I mean, we have joint effort, we have registries, it's very difficult to define and move this forward. And then there is consumer health. Don't know if you're aware of apps. You can go to the Apple Store and you can download all sorts of apps, not just for gaming, but also for health advice, for cancer advice, and patients are using this, and even providers in the US. In fact, in the oncology world, they have so many guidelines, they have so many regimens. I never knew how you keep track of it, but I figured out. You have an app. You just type in the patient characteristics and it will tell you regimen X, Y, or Z. Likely not that simple, but what I'm trying to get at is the changing landscape and the changing techniques we use and support that will influence our practice in the future. And so significant advances in technology and use of information will impact oncology and cardio-oncology practice over the next decade, most certainly. And there are also changing concepts within cardio-oncology. You likely have seen this one, the expert consensus on multimodality imaging, the American Society of Echocardiography and the European Association of Cardiovascular Imaging. And when you look at that document, the first table that they presented was the type 1, type 2 chemotherapy or cancer therapy related cardiac dysfunction, CT-RCD. And type 1 being structural damage, irreversible damage, classically seen with doxorubicin. Type 2 being this functional injury, irreversible, and classical example would be trastuzumab. So that's the concept that was still out there. And it goes like this in a graphic form, that we would think that patients on anthracycline-based therapy usually do fine during the active treatment, but then the cardiomyopathy develops during follow-up, whereas with the type 2 agents, trastuzumab, the drop in ejection fraction cardiac function is during therapy. Once it's stopped, there's a rebound and recovery and no subsequent decline. Now, we looked at this in a cohort of patients who underwent ICD treatment. So these are patients all with cardiomyopathy, heart failure, several years out from diagnosis of their heart failure, and for the cancer patients, several years out from cancer. And this was the common starting point, and it was very similar across all three groups. And we looked at what were their cardiac function, their EF dynamics over time. Was it a plateau? Did it increase by 10% over time, decrease by 10% over time, or did it go up and down by 10% over time, which we claim variable or defined as variable? Now, when you looked on the bottom, the non-cancer cohort, ischemic heart disease, dilated cardiomyopathy, there's about a split into even thirds as how these patients go. A third would plateau, a third would have an increase in their ejection fraction over time, and a third it would be variable, so in rough terms. So that's like an equal spectrum. When we look at the cancer patient, it was different. You can see that the purple contribution here is much larger. Almost half of this cancer population, not anthracycline cardiomyopathy in the middle, had some variable dynamics in the EF over time. And then 24%, or a quarter, had a plateau, and the others had an increase. Now, when we look at the anthracycline, the cancer patients with anthracycline-related cardiomyopathy, it was 3/4 had a variable course in their ejection fraction over time. The EF went up and down. It wasn't static, and it was certainly not this constant decline picture that we often have in mind. In fact, this decline, this decrease was not seen. The others had a plateau, or some had an increase. So it's very dynamic over time. It's not static. And we also looked at the survival-free of ICD therapy, heart transplantation, LVAD, and compared this amongst the group, the cancer, anthracycline-related cardiomyopathy on top, and no significant difference whether you compare it to those with cancer and non-anthracycline cardiomyopathy or clump them together, ischemic heart disease, dilated cardiomyopathy. The ischemic heart disease group still had the worst outcome. So that's still in our cohort here, was the cardiomyopathy with the worst prognosis. These patients also had similar changes in symptom status, NYH functional class over time, so no indication for higher progression of heart failure. And there was also overall no higher burden of fatal arrhythmias when you looked at the groups. And I'm putting this all out there because historically, and we've seen this yesterday presented, this manuscript by Mike Felker from Duke, looking at patients presenting to the heart failure clinic, and then what was the etiology after a thorough workup. As we saw yesterday, it was 15 with doxorubicin-induced cardiomyopathy. They were claimed to be among the worst in the outcome. This would be equal to amyloidosis infiltrative cardiomyopathy. But the question has always been why. Progressive heart failure, fatal arrhythmias, why such a poor outcome? And hence our interest in the study. And there was also a question, is this still true? This is from the 1990s. We're in a different era now with different medications. So from what you've seen, I think that this concept at least has been challenged, and we did this in the case discussion yesterday as well. I'm glad we did. When we looked at trastuzumab-induced cardiotoxicity, something that also came up yesterday, our concept here was very much shaped by what Mike Dewar at MD Anderson published a few years ago, and this was just based on 38 patients undergoing trastuzumab therapy. Most of them had anthracycline exposure before. You see the drop during therapy, and then it bounces back up. Whether or not you give cardiovascular medications, you just have to stop the drug. And then you can sequentially expose the patient to trastuzumab, and there wouldn't be a recurrent drop. So that's really shaped our understanding of this type 2 pattern. But what I think is interesting is that this group never really reached full baseline level. If you look closely, then the F never really went truly up to the same level they were before. There are likely some who had irreversible damage. When we looked at our cohort at Mayo, all patients ever treated with trastuzumab since 2001, what we saw was that 80% of the patients had a decline in their ejection fraction of some form or another. 44%, 10% or more, and 4% developed heart failure. And when we apply this ASE document definition, 17% had cardiotoxicity or cardiomyopathy. And what's also pertinent is that almost 20% of the patients were not able to have a fully uninterrupted course of trastuzumab therapy. So it does have an impact on their cancer treatment. And when we looked at the reversibility of these EF declines, and looked at the different combinations of holding trastuzumab, providing cardiovascular medications, the best turnout in terms of reversibility, you see it shaded in orange, was in those in whom trastuzumab was held and cardiovascular medications was provided. In fact, when we took a look at all patients, new or intensified cardiovascular medications, you can see the shift that's occurring, the reduction in those left with irreversible cardiomyopathy, that's in green, is drastically reduced with these medications. So again, from what Mike Dewar showed, and that it almost doesn't matter if you provide or do not provide cardiovascular medications in terms of reversibility of this, I think there's a little bit of a challenge to that concept too. And then comes the long-term outcome after trastuzumab cardiotoxicity. So there are those who say it doesn't matter. Once trastuzumab is stopped, there's no further related risk. And these supporting data come from the HERA trial. And you can clearly see on the red line, trastuzumab exposure to 1 year, on the green line for 2 years. The increase in cardiotoxicity of events was strictly limited to this exposure time. After that, the line flattened out. But this is trial data. When we look at real-world data from networks, this is one from the Cancer Research Network, we see that over time, the incidence of clinical heart failure in patients treated with trastuzumab alone continues to increase, whereas it just barely in the anthracycline group, not much different to those who didn't have chemotherapy. And the highest risk is in those obviously exposed to both anthracycline and trastuzumab. And so real-world data suggests that the long-term cardiac risk of trastuzumab might be a reality, not just some fiction or thought. It was first presented in this paper in JACC a few years ago. This is based on the SEER database and were Medicare patients. And one criticism was that the rates of heart failure are so exceedingly high. Within 3 years of therapy, almost approaching 50% in the combined anthracycline trastuzumab group. This was just felt to be too high, but the same trend, trastuzumab more so than anthracyclines. And so really some awareness in this area, and I think something we need to look in further as is this real and what is this due to? And it's also been said and published and shown in multiple conferences that over time, cardiovascular disease becomes the leading cause of death in breast cancer patients. So this is a paper widely quoted and cited, and you can clearly see it. But what I would like to add is that this study was done in elderly females, 65 and older. In fact, most of the increase was seen in those 81 and older. And so this is exactly the age group in which cardiovascular diseases are the leading cause of death anyway. So I think it's really gets then a little difficult to conclude what does that have in particular to do with malignancies. But there are other data, and this is from a study that included not only elderly women, but all comers, and you can see that women with breast cancer in red overall had a higher mortality over time. That is not surprising, but I think, and I would like to direct your attention to, is that the cardiovascular disease mortality was also increased over time. Starting after 10 years, women with breast cancer also had an increased cardiovascular disease mortality. And the question is this cancer therapy related? Is this modifiable? Can cardio-oncology make a difference? What is this due to? Common cardiovascular risk factors, poorly controlled, effects of therapies, etc. A lot to entertain. And when we look at cancer survivors in broader scope, not just breast cancer, but also multiple myeloma patients and others, what we'll see is the effect of double hits, cardiovascular disease and cancer. So best outcomes, as we would expect for those who have no cancer, no cardiovascular disease. Second best outcome for patients with cancer and no cardiovascular disease. So they have a better outcome than patients with no cancer but cardiovascular disease. Isn't that interesting? And then, so it was a matched population-based cohort study. And then worst outcome for those with cancer and cardiovascular disease. So it shows you the impact of cardiovascular disease in the cancer population and in general. And so it definitely is not trivial. But the question is, are the cardiovascular disease needs the same in cancer patients? And then very importantly, do the same guidelines apply? Cancer patients historically have been excluded from all major trials. And so can we really just extrapolate? Can we really just infer from what we have? And so we looked at what's our practice at Mayo for those with active hematological malignancies, what's the incidence of acute coronary syndrome, the management and outcomes. And what we found was that acute coronary syndrome is not common, really not common, but it's commonly managed not in keeping with guidelines. And so That's one conclusion, but the other is that the guidelines or the therapies recommended in the guidelines would have actually led to better outcomes even in these patients, even with thrombocytopenia or even with other elements you can factor into the equation. So this is, for instance, with aspirin. You can see this is, we're looking at survival, and in orange is the aspirin-treated group, and we try to, with some inverse propensity weighting, try to adjust for differences in baseline characteristics. But these patients did better. If they were started on aspirin, they did better with beta blockers, and they did better with ACE inhibitors. But only a minority of these received all of them. And so when we looked at the contribution to outcome, so overall mortality you see plotted in green, 25% of the overall mortality was accounted for by cardiac death, and 75% was accounted for by non-cardiac death. So that goes in the bigger scope, I mean, and relates to the question, what does cardiovascular disease matter? But what does it matter is if you took into consideration, had we applied aspirin and beta blockers as the guidelines say in acute coronary syndromes without thinking that second thoughts that these are cancer patients, we could have reduced the risk here to 7.1% based on, if we apply those data. This would have shifted the cardiac mortality curve down to this level, and this would have shifted the overall mortality curve down to this level. And I leave it up to you to conclude whether this is meaningful or not, but it shows you how still, I think, cardiovascular disease does have a very graphic impact. And it's not new. It's from the very start of this field was really outlined. This is Ron Vitalis from Stanford who put this out and concluded that many cancer patients are not receiving treatment consistent with heart failure guidelines when it comes to cardiomyopathies, and that there's a huge opportunity for collaboration, and hence our meeting here today and all the efforts we have in our institution and clinics. And it's really relevant and pertinent because the timing of the initiation of therapy really matters too. This comes from Italy. Cannonale and colleagues who've published a bit on this show that the response, and this is recovery, LV recovery potential, this is what response means here, really the chances of this declines quite rapidly after, as far as a function of time to recognition. And I'm not saying, and we haven't seen it, that these patients who are towards the right never ever increase their cardiac functioning again. In fact, that's also very much under debate, but the point is that it's in those non-responders or partial responders, this group, which was 60% in their cohort, these are the ones, when you look at the columns for mortality, heart failure, and even arrhythmias, those are the ones that really had the events. It's the ones left with an irreversible or partially irreversible decline in their cardiac function. And interestingly enough, anthracycline is not the entire explanation. It's not all of the story. And in 2014, the ACC, we did a survey among cardiology, mainly academic cardiologists and fellowship program directors, as to gauge an understanding of what is their level of understanding of this topic. And to the left, you see the impact of stopping anti-cancer treatments on cancer outcomes. This is what we asked the cardiologists. Do you know what implications that has? And as you can see, it's a nice normal distribution curve, but it really falls off to the right. And the ones who graded themselves at 5, excellent. I mean, there were just a few. That means that over 90% have still room for improvement. And the same for the oncologist, as far as understanding a slow response to cardiovascular disease as they evolve in the cancer patients can have. I mean, how dramatically things can change in case of a cardiovascular problem. So plan has taken off, and we're looking just in the final minutes here at the pilots, at those that would be you who are trying to direct and steer where are we going from here. And when you look at this, at least that's sort of my view, look at this from 30,000 feet, I see a number of dots in this field. And I mean, there are all sorts of people clustering around, sometimes hard to define. And you can say it's a sky full of stars, a lot of stars on the scene. there are a number of moving parts, or it's a variety of elements, however you want to put it. But I think what we're really trying to accomplish and should be out for is convergence. And we're taking this extensive spectrum of malignancies, if you think about it, it's so broad, and this extensive spectrum of cardiovascular disease, and we'll blend it together. And it's a huge effort if you think about it, spanning all of oncology, hematology, and all of cardiology, and putting it together in one discipline. I mean, that is huge. The question is, how do we connect the dots? How do we do it, and how do we structure this? I think this is one of the pressing questions in the field moving forward. There have been some pieces for Generation Next as far as educational pathways, but I think it really hits home. This is right at the core as what we need. We do need good cardio-oncology training, and you started seeing Med&Onc residents, and it's really, really important. So within our working group in ACC, we've formed a training working group, and we're in the process of defining the goals of what a training program should entail, and then which different criteria and structure should there be for level 1, 2, and 3 training. So we have a consensus, and it's not just a scatter. But when we look at these guidelines, they usually form for training programs if we educate our next generation. The foundation, and the question though is, what is our knowledge base? That's really another question, and in this call for guidelines that we have in the field. And we've just taken an example here from the Spanish medical oncology cardiotoxicity guidelines. What is the evidence base? Look at that. So this is the meat of the paper. This is the central table, and you can see there are a lot of 8s. Grade A strength of recommendation, 75% of the recommendations, which by their definition implies that good evidence to support the recommendation. Okay, and we'll look at the next column, and it's the quality of evidence. 90% quality of evidence 3. That means opinions, clinical experience, and committees. That's what that means. It's sort of the level C evidence in the American and European guidelines. So a lot of this is by consensus, by strong consensus, we would say. But we're in good company. So, because when you look at this was recently published, when you look at all of the American, all of the European guidelines we have in cardiology, and you stratify by class of recommendation and by level of evidence, you can see in the American guidelines, even class 1, that's what you should do. That's our terminology for what you should do, everyone should do. The level of evidence A, this is randomized trials, right? So just 5%. I mean, this is really depressing as far as the level of evidence and strength we have. But so the point I'm trying to make is that in cardio-oncology, we do not necessarily need to be afraid as coming up with protocols, coming up with consensuses that we develop. And I think if we wait for the level of evidence to do anything, we'll never get there. Now, just looking at another example from the American Society of Clinical Oncology, and just looking at their first recommendation, which cancer patients are at increased risk. They have this nice outline, either low risk or high risk. And Eduardo, you mentioned some of it that you utilize in your stratification, who should be seen in the cardio-oncology clinic. The question, though, is this based on absolute evidence, or is there a loophole? So we looked at our 300 patients in our registry from the cardio-oncology clinic, and for these patients we had follow-up echocardiography data. And what we found is that the ASCO suggestion recommendation here in the stratification, low risk, high risk, doesn't really work out. I mean, the incidence of cardiotoxicity is the same in both groups, whereas when we used our Mayo cardiotoxicity risk score, there was some stratification. It's still not the greatest. It differentiates, but I think we all would agree that it still needs work and needs to refine. So that's why I said yesterday, it's not so easy in clinical practice to define. So what do we use at Mayo to stratify as far as who gets referred, but also as far as monitoring and treatment? We stratify by medication risk, and this is how we built the risk score as far as the level, and then also for patient-related risk scores, a point each, and then you combine it, and this was 5 years ago. And the score distribution, what we had so far in our clinic was like this. Low-risk group was less than 7, high-risk group was over 7. We had a nice bimodal pattern. And there were, though, not equal patient numbers in each of these strata. So when you normalize and have equal patient number in each stratum, you would see this performance of the myocardial toxicity risk score, and this is something that we might be able to work together on as far as getting the patient numbers to confirm this is the predictability. But then here comes another interesting question. What do providers need for clinical practice? I mean, is this something they need? And even if they had guidelines and how the tools, would providers follow them? I mean, even if they had it. So if you look at the NCCN guidelines for survivorship, they have it out there that anthracycline-induced cardiotoxicity can occur and that you should definitely, it's a recommendation that felt too strong to obligate people, but they made a strong case to check an echo at least within the first year after completion of anthracycline-based chemotherapy. And so we looked at this now at the US. It's a huge database of millions of insurance claims, the Optum database, and we looked at all patients with breast cancer and lymphoma treated with anthracycline-based regimens, and how many had echoes, how many had BMPs, how many had both. And so what you can see, if we look at echo alone, there was a 12% increase over the years, over the decade, of some progress, but you can also see that still, I mean, less than half get an echo within 1 year. This is, I mean, what the recommendation was. So still a lot of patients are not receiving what they should as far as cardiovascular surveillance. And the NCI had this meeting in June last year. We had our Changing Hearts and Minds meeting and a roadmap for the future for research. For those interested, I know you do have a key interest, and you showed some very nice even preclinical studies that they do. So if you're interested, they provide more recommendations what should be done. Induced pluripotent stem cells was one of the topics of interest that was proposed, but it really is research to inform practice, to inform training, and to improve patient care. And as a final conclusion, this is just published in JACC as far as preparing the cardiovascular workforce. I think we've covered all of these, and the bottom ones remain the key, which is advocacy and which is stakeholder partnerships and bringing folks together. It's really, if we're among, as cardiologists talk about this, it really doesn't get us anywhere. We need the three women here in the front representing the entire shield of cancer care. But it really needs a joint venture. And so I'm really grateful for this meeting and the partnerships where we bring down the roads the cardiology groups, the oncology groups, engage the clinicians, engage the researchers, and have meetings with a goal as far as what we would like to see this field moving towards to, maybe have standing meetings. And also raise your awareness that now in Frontiers for Cardiovascular Medicine, we do have a section on cardio-oncology, so sort of like a dedicated, or at least open access journal. And when we look at our competitors, I'm sure you're aware, there is another one from JACC. Our fees are lower, so if you want to submit with us, we give you a discount. But from cardio-oncology, from hype to productivity, I think that's the bottom line from what we've seen yesterday with the case presentation, today what we've heard. We're going through this phase of everyone being excited, maybe some sobering experiencing, but then hopefully we'll reach a plateau of productivity, moving it forward. So in summary, the face of oncology, hematology has changed significantly over the years. The times will continue to change in view of the new drug pipeline, the technical and digital developments, and the changing healthcare environment. The cardio-oncology revolution has started, is now turning into an establishment, and there is an urgent need for the structure and standards and training education in cardio-oncology as we're moving more to an organized form, and an imminent need for research as well as quality and outcome parameters to be integrated, and a paramount need for goal-directed meetings and working groups in the fields, not just, I think, just presenting the same data, the same studies, the same observations, but really trying to go into the future and moving this forward. So the plane has taken off, and the question is, hopefully you were able to define yourself in this, and hopefully we moved you forward to the next stage. And I'll leave you with this. At least it has subtitles. But for cardio-oncology, if the lion comes, if the disease comes, we run together. We don't run away from you. And with this, thank you so much for your attention. Muchas gracias.
Thank you, Jurek. All the panel come to the table, please.
Hola, ¿me oís? ¿Me oyes? ¿Cómo se llama? Eduardo. ¿Nos oyes, Eduardo?
Sí, te oímos, César. Ana, ¿estás ahí?
Sí, tenemos que dejaros. Muchísimas gracias, muchísimas por la oportunidad. La calidad técnica de la transmisión ha sido excelente y la oportunidad de poder asistir a la sesión, pues para nosotros ha sido muy, muy interesante. Son las 10 ya y lamentamos no poder quedarnos al coloquio. Muchísimas gracias otra vez.
Gracias a vosotros, César. Ha sido también un placer contar con vuestra aportación y un saludo también especial a José, que ayer lo hizo de forma extraordinaria. Un abrazo.
Un abrazo y adiós a todos.
Is there any question in the room for the audience? Manuel, please.
Ahora vas a preguntar lo que es todo que dije. No, ¿qué pedimos hoy? ¿Qué pedimos hoy? De cambio, que hablar inglés, entender y escribir, ¿verdad? Eso parece la primera cosa. Segunda, un mundo se abre, otro mundo, que es el de la cardio-onco. La charla fue insoportablemente larga, es una cosa que aprendimos, no se puede dar una charla de una hora, no la puede dar ni un premio.
So you've shown us that nowadays we can detect a group of patients that are at high risk for developing cardiotoxicity. But when we detect these patients, right now we are just like doing more, I don't know, intense follow-ups. We are not like trying to prevent that cardiotoxicity. Do you think that in the future we might need to treat those patients, I don't know, with beta blockers, ACE inhibitors, or sacubitril valsartan in order to try to prevent that cardiotoxicity? Thank you.
Yeah, there's, so I can tell you at the level of the NIH, that's where most of the interest is. It's primary prevention being active before or during. When you try to come in with a proposal to do it after in the survivorship population, it's really hard, it's very difficult. In fact, the NIH, because of the poor outcomes in the past, they don't even have a panel for survivorship. It's not a dedicated panel. I don't know if it's here in Europe, so that's difficult. So in general, most of the interest right now is in this area. What we have available, we have a number, we mentioned this yesterday, a number of small studies as far as for anthracycline-related cardiotoxicity, for trastuzumab. We don't yet have the trials that showed us that there is a preventive benefit of starting beta blocker ACE inhibitor having less of an incidence for cardiotoxicity. Daniela Cardinale just published the ICOS study looking at enalapril.
Salamanca, ¿estamos oyendo ruido? ¿Es Oviedo? Bueno, estamos oyendo ruido de fondo, no sé si se puede arreglar desde la parte técnica. Sorry, Herman.
Yeah, so Daniela Cardinale, she just published the ICOS study, and the question was starting enalapril, at which point in time? Do you do it from the beginning, or do you do it in response to troponin elevation, and what's the outcome? And so limited outcome assessment, but still the bottom line from conclusion was you can start it once the troponin elevation is there. You don't have to start it from the get-go. It wouldn't necessarily make that much of a difference. But that's a very excellent question in contended field, because others feel different. They feel like once the patient has received anthracyclines, for instance, the horse is already out of the barn, as some people say. So at that point, you're trying to catch up. You're one of the spectators, so the ones who have the last boarding call. So being ahead of the game, and some would say, why don't you just give it? I mean, what's the downside of just giving an enalapril or beta blocker? I mean, what's the problem? But that's a question to the oncologist and hematologist. I mean, if we were to do this, have you encountered problems with that?
No, not really, because it's usually low doses and they don't really have bad outcomes in our patients.
But that's exactly the other question. Low doses, you said, and so in cardiology, we're so tuned to have high doses, right? I mean, we're more like cowboys, and so we're really like to, if we do it for real. And a number of the heart failure trials too, I mean, they've shown that the higher the up titration, the more you get to, I mean, as far as this goal, the better the outcomes. So that's another question I think would call for active investigation is, what are actually the doses required to see an effect in this field? I mean, are we good with enalapril or lisinopril 2.5? I mean, like, what does that mean? And so it's really a question, isn't it?
In this aspect, I think that it's completely real, and when you face the patient in front of you and you know that with the score or with the cardiovascular risk factor or whatever, you see that this patient is at a high risk of cardiotoxicity, you would like to do something. But it's true that we are trying to titrate the doses of all the medications for heart failure in heart failure patients, and we don't do it in those. And also the heterogeneity of the studies with the dose is very high, and some of those patients had secondary symptoms and adverse events of the chemotherapy, and during the treatment it's difficult to even low doses maintain the regular medications. But when you have nothing, I think in the high risk patients, I would like to try.
Yeah, I agree. I mean, they might already have a baseline risk. And the other question we entertained yesterday was, once you started, when do you stop it? I mean, that's the other aspect. I mean, once you commit a patient to this, and it's a frequent question we have in our clinic. You might have seen them too. Doc, can I stop now? I'm done with my therapy, and what's the point?
I have a question for Dr. Herman. Thank you for your excellent talk. What role do you think that genetic testing might play in this kind of stratifying risk of these patients? Because some recent work suggests that some patients that develop left ventricular dysfunction have already a genetic mutation.
Yeah, so a few weeks ago, I mean, there was the Titan mutation that made some headline in the Circ paper. There are some better data, I would say, in the childhood cancer population as far as how genetic panels work out and could help as shifting the AUC curve for predictability. It's though interesting, when that group looked at it once, they had a good result. When they looked again, maybe not so much. And so it's inherently difficult. Again, this is something that would need to roll out to a consortium like you have, the CyberCV, or a larger group as far as finding the numbers, and to do this in the adult population. As you saw in the Circ paper, it's a huge list of authors. It's a huge undertaking as far as defining the risk, the genetic risk in this group. But I fully agree, it's definitely there. And in the tactics trial that we mentioned yesterday, even though it's just 450 patients, we do have a pilot aspect in there looking into pharmacogenomics. So I think there's not only genetics as far as risk prediction for cardiotoxicity, but it might also be pharmacogenomics to look at response to therapy. I mean, because some of them might not respond to beta blockers, and there could also be traits that play a role.
I don't know if there is any question. Pedro.
I don't know if in
I
Salamanca.
would ask for Salamanca, so.
Ask in Salamanca first.
Ana, do you have any question?
Yes, we have. Thank you. No, first of all, congratulations, Dr. Herman and Dr. Fatarain, for your interesting and excellent presentations. I'd like to ask Dr. Herman two questions. The first one is, do you have any special cardiac monitoring protocol for CAR T cell therapy? Would you mind explaining it to us? And the second one is, do you have a primary care cardio-oncology program for lung survivors? Thank you very much.
Anna, for your contributions, and I tried to highlight your position in this in the Spanish societies. And first of all, congratulations to you of what you've done and you've accomplished, as said, in a very short period of time, all you've done. And so the second question, I asked this question to Sonia. I didn't know that she was primary care and interested in public health at the time, but I asked exactly that. How do we deal, or how do you deal, with an ever-increasing survivorship population at risk of cardiovascular diseases? So I think it's a little bit nearsighted to just look at what we entertained here in the beginning, at the pre and during treatment cardiovascular care and what should we do. I think it's really imminent to look also at the survivorship. I call it the survivorship gap, because there's really patients fall through the gaps, through the cracks, as far as their follow-up, because no one really at some point is responsible anymore. So it's not they're out of there, dismissed. I don't know, how long do you follow your patients after cancer treatment?
We're still pending the protocol because it's very difficult to make a definition on who should be considered a long-term survival from cancer. I mean, should we only take into account the time from the cancer cure, or should we also follow up metastatic patients with long survivorship? Only patients with some types of cancers and not all types of cancers, and what regimens of chemo or treatment should receive this follow-up? What do you do at your clinic?
Yeah, we have, so they're both in hematology and in oncology. There are two individuals who've taken this on to build the survivorship clinic, and they've developed a survivorship care plan, and also radiation therapy, very much so. And so the patients go home once they complete their therapy with a complete list of recommendations as what should be done, and there's a section on cardiovascular follow-up. But we've seen, I mean, so they follow for 5 years maybe?
Yes,
at the most?
especially in lymphoma. I think in diffuse large B-cell lymphoma and Hugm lymphoma is 5 years. But the problem is, for example, in Hugm lymphoma, the problems with cardiovascular appears at 10 years.
Exactly.
So the patients are not in our hands at the moment.
And there comes this famous statement that one of my colleagues in oncology made. It's like, anthracycline cardiotoxicity, what do you mean? I never see it. And so, the primary care physicians should be aware of it. And so we did at Mayo many years ago, we did grand rounds, just medicine grand rounds for that matter, just to raise general awareness that once they're dismissed from their primary oncology care into just general primary care, that this should be on the horizons. Because we've seen patients who just really fell through the crack, literally, and then misdiagnosed as, for instance, their dyspnea was misdiagnosed as asthma, reactive airway disease. They could never really match up to peers in school, childhood cancer for survivors, for instance, and then at the end it was advanced heart failure. So for your first question, this is, Anna, this was what we do for these patients as far as integrated screening. And the CAR T-cell. CAR T-cell. Yeah, for CAR T-cell in particular, so we get to see, we have the honor of seeing all these patients with any pre-existing cardiovascular issues. They were usually excluded from the trials, as most would do, right? And so though we have now something like tumor boards. Every Monday morning, that CAR T-cell program, the group gets together, and then we're just ad hoc members. Each time the patients have some cardiovascular issues, we get involved. So we've now, so it's on an ad hoc basis. We've seen patients with atrial fibrillation. That's been a recurring theme and what to do. We've now moved towards amiodarone, prophylactic amiodarone. just for the time of their actual treatment, similar to what you see with surgery, right? Which has a Class 2A recommendation, those guidelines. But that's what we do for the CAR T cell at risk for AFib. Then we've seen those who had some cardiac dysfunction, and there it's really the question and the dynamics, I think, is very similar. It's the cytokine release syndrome, and something similar to what we see with SEERS, severe SEERS, or sepsis. And I don't think it's necessarily irreversible as far as pulling these patients through. So that's not an absolute contraindication. But then we've seen those who had with lymphoma, for instance, had pericardial involvement, or had anterior masses where there was a question: does it infiltrate into the pericardial space, and what do you do? And so our hematologists were convinced that if they started CAR T cell therapy, they would burn a hole into the pericardium. And so it's really on a basis as we see these patients. I think, again, some real world experience. Those patients excluded from the trials. And have you had any such cases, Anna? Let me give the question back.
No, our hematology department has started this protocol several weeks ago. So I think that only one patient had received CAR T cell therapy in our hospital right now, and we have saw him, evaluate him at cardio-oncology clinic, but everything was okay for right now.
Probably this is a new opportunity to do the follow-up of this special and small group of patients from the very beginning, and to see if there is any specific cardiotoxicity. It is a proposal for a new registry for this heart or cardiovascular toxicity for CAR T cells.
This hospital is the only one in Madrid until now approved for CAR T cell therapy, and we are beginning with the first case next week.
Yeah, the cost is $500,000 in the U.S. For that treatment, so it's not a huge population.
Not that much.
The point made by Anna regarding primary care is really important to me. It's important also to our department because we are very much involved in the relationship with primary care. We have protocols for all the pathologies and follow the patients according to these protocols. And Anna, my suspicion after your question is that you already have started to manage this kind of patients with primary care doctors. Can you tell us how do you organize this?
We are working right now on this, so we are going to have several meetings with primary care in the next weeks, because I think I have the same opinion. It's very, very important that primary care are involved, because we have a lot of patients and they can detect early signs of cardiotoxicity earlier than us or than oncology or hematology doctors. So I totally agree with you, and I think that we have to work more and more with primary care doctors.
About this topic, Anna, I also have a question. Is this initiative by your own hospital, or is it in the hallmark of the group of cardio-oncohematology from the SEC that I know is starting also with that program with primary care? And I don't know if you have any data of how is it ongoing.
Yes, we have a document with Cardiology Society, also Oncology Society, National Society, Hematology Society, and also primary care. But right now we have to start with working with primary care from each hospital or each cities, because from the cardio-oncology working group also think that is one of the most important issues now to manage.
Pedro.
Well, congratulations to Gregorio Marañón for the initiative of the Cardio-Oncology Clinic, and thank you, Dr. Herman, for your talk. Wonderful as always. I have a critical comment about cardio-oncology. I don't know if we are creating a problem rather than solving a problem. And this is very important. We are teaching the oncologists to ask for troponin and to ask for NT-proBNP, as we have done with emergency departments several years ago. Now, if you ask the cardiologists about how to deal with emergency departments, we every day see almost half of the patients with chest pains that with no cardiological origin just because of the troponins. We started 4 years ago our cardio-oncology consultation once a week, as you are doing, and we follow what you have shown is these clinical risk factors or scores. One of each is age over 65. 60% of our oncology patients are over 60. This means that we have to see all these patients in our clinics. So 4 years after we started, the clinic is collapsed. We have had to start it to see patients in the afternoons, and we are seeing patients just because the troponin has risen or because the NT-proBNP has risen. And in some of the patients, they are terminal patients with renal failure, metastatic, with ascites, a lot of problems that, so I'm a little skeptical regarding the use of troponin and NT-proBNP. So here is my question. You have talked about artificial intelligence today, and probably here could be a solution. The other solution has been risen by the audience is trying to follow community examples of heart failure. This is what we would like to start in Salamanca, a community a team regarding cardio-oncology. But my question is, are you using any artificial intelligence tool or algorithm trying to identify what patients would really benefit to be seen by us? Because otherwise, we are not going to be able to afford the amount of patients that cardio-oncology are treating without any proof right now that our intervention improves the survival of the patients. So this is my question.
So what would you say? In which group are you then? Are you a pilot? Are you a passenger or a spectator?
I'm the engine. The engine.
But no, this is absolutely paramount. And you might have seen it shine through the talk, the skepticism I have to a certain degree, and that we shouldn't stop thinking and challenging the field. And I mean, the concept that we have, I mean, type 1, type 2, any concepts that we have, from a very practical perspective, what you're alluding to, Eduardo and I, we had this discussion here yesterday, today, and how do you do it, how do we do it? We've always had a sort of restrictive approach to our cardio-oncology clinic, because we were very much afraid of what you mentioned, that you would go too big, too fast, and can't accommodate, and you have different mentalities and different strategies. One is the open arms, that, I mean, everyone can come, and it's good for the referral practice and to build that relationship. But so yesterday, at the end, I mean, I asked, I mean, what problems do you see? And I think for them, who would they refer? That's sort of our approach at Mayo, is, I mean, who do the oncologists and hematologists in the bigger picture, in the bigger scope, who do they feel need to see us? But the very critical question to answer is, what difference do we make as a field in general? And that is, that needs to happen. And so one of the last points, that's why I mentioned the outcomes. And for as you start your cardio-oncology clinic, I think we need to have outcome metrics and quality aspects. It's easier to build from the get-go as you start your clinic, define these endpoints, and then once you're through a certain time period, look back how did that change? So I think that is something that definitely needs to happen. And then, as I mentioned towards the end, I mean, even at meetings, so I appreciate, I mean, the sparky questions and ignition even here as what do we need to do? And so there's a lot of talk at times, as I mean, presenting the problem, but not working towards a solution, or as you say, creating maybe a problem that's not there in the first place. And then, I mean, but to really work together as I mean, we all get a sense that there's something still there that's unmet, an unmet need that we can address. But I think it's so critical to move on to the left, to my left of the table, to engage and continue to engage as what we feel is needed. We don't, I mean, the administrators might like it, but we don't necessarily need more patients in cardiology. And so it's the opposite. So, I mean, we got to be smart. And I think this is definitely work in process, but it needs to happen. And in Spain, in Europe, in the US.
And are you working with any artificial intelligence tool right now, the Clínica Mayo?
So we don't really have, as far as for triage purposing, or to have like a fancy app, or to have any computer that would tell us what we're working on, what we're doing. Number one is in the EMR, and one system in the US has this already in place, is when the oncologist orders a potentially cardiotoxic medication, a question will pop up. And they will ask a few questions, like similar to what you do, Eduardo. Age the computer usually has, but I mean, any cardiovascular diseases, symptoms, etc. And then the patient gets flagged as either low risk or high risk. If they're high risk, then automatically a cardio-oncology consultation will get prompted or scheduled. And then the oncologist, hematologist still has a chance to say no and decline it at that point. So their work as far as systems approaches EMRs. The other one, as far as artificial intelligence, what we do and presented just at HRS, is the EKG. So we do, Paul Friedman has a patent on this and has a very much invested interest at looking at the surface ECG as a predictor for a reduced EF. So that's an ongoing effort. As using it as a screening tool beyond biomarkers and those. And from the analysis are still out there. Hopefully you see it published soon as far as how these compare with NT-proBNP, EKG and NT-proBNP. So those are the two main areas that we're currently working on at Mayo.
I would like to give a brief opinion about if we are creating a problem. I think the education of all the specialties in the problems of the other is the answer for that. Once the oncologists learn which patients has to derivate, and once we understand exactly what is the problem for the mate that is referring this patient, it's going to be easier. At the beginning of our very short experience, we started in September. I received many patients just for risk factors. And also I started to receive terminal patients with heart failure. And they suffer with dyspnea, with edemas. And the treatment of this condition relieved the symptoms. I think I improved the quality of life of those patients, even though I knew that I would not affect the prognosis. I think in those patients, cancer patients, it's also important not only the survival, but the manage of the patient till the end. And if in the graph that you show about anthracycline in lymphoma, no anthracycline, and the different prognosis, when they develop heart failure, of course, the finish is at the same point, but the area under the curve is not the same. So I think this area under the curve could also be time for the patient and quality of life. And I think this is also our role in those patients. Yes, big challenge, and how to organize it. Any other questions? I have a question for Rafa that is very quiet. Yesterday...
I'm not an oncologist, an hematologist, I'm not a cardiologist, I am a liver specialist. But tell me, please.
Yes, but you are now developing some work with the inflammatory disease, and also, as Herman has shown, the immunotherapy and the intervention of immune system in the cure and toxicity of cancer is going to have a role in the next future. Also, we have Javier here, that is a clinical immunologist. And what is your view in the setting of the liver cancer, where you use direct molecules and also inhibitors of the checkpoint? What is your view, how this immune modality and inflammation may affect the toxicity, and how can we help you to check the cardiovascular morbidity in your patients?
Well, I think there are several bidirectional ways to face this problem, because we probably promote some cardiotoxicity associated to the use of PD-1 inhibitor, for instance, but we also receive patients with hepatic morbidity associated to the use of this immunotherapy. So I think the way is to promote a different way to approach the problem by creating units dedicated to the management of these particular immunologically mediated diseases. Because we can face patients with autoimmune hepatitis without liver cancer, but also we can see myocardial contribution of the management of this problem. And I have to say that in our CIBER, our cooperative network research, we are creating a group to try to face this problem from a clinical point of view, but also from a research point of view to obtain a lot of knowledge as soon as possible in this field. But I have also some comment related to the relationship between the management of oncology and hematology therapy and the liver. And I think probably we should be the second plane to take off, because we see a lot of patients referred by hematologists and also by oncologists due to liver disease in two different ways. First, patients with oncology, an oncological problem with previous liver disease, common liver disease, for instance, fatty liver. And also we see a lot of patients with the development of portal hypertension or some kind of portal hypertension, probably unknown at the beginning of therapy. So probably the next flight should be probably the liver-related oncology and hematology problems. And I hope to have a meeting like that in the next future.
It's quite late. Any other question? Last question from Salamanca? No? Okay. So it was a pleasure. Paco, I don't know if you want to say goodbye.
Yes. 2 seconds. Salamanca, Oviedo. Bueno, amigos de Salamanca, tenemos que terminar. Amigos del Marañón, todos los que habéis participado en la audiencia, en el panel. Dear Jörg, many thanks everybody for coming to this meeting, for being connected with us, and thank you very much for your interventions. Thanks.
Ahora.